Hi everyone. Today we're going to talk about reproductive health needs of adolescent girls with adult congenital heart disease. I'm Vicky. I'm a consultant obstetrician and gynecologist, also a maternal fetal medicine specialist. So, up to about 90% of patients with adult congenital heart disease now live past 40-year-old. And congenital heart disease can be as mild as bicuspid aortic valve, a ventricular septal defect, or an atrial septal defect. Whereas on the extreme end, it can be as severe as someone living with complex congenital heart disease, such as single functional ventricle, those with Fontana circulation, those with cyanotic heart disease and pulmonary atresia, as well as hypertrophic cardiomyopathy, and the list is non-exhaustive. When we look at the babies born with congenital heart disease in the year 1980s, less than 90% of them would have lived till adulthood, whereas those born in the millennium, especially those born after 2010, more than 90%, and I would say about 98% of them would live beyond adulthood into their reproductive life. So what are the issues faced by these young adult women with adult congenital heart disease? Many of them will have menstrual disorder. They feel that they are not as attractive, especially those with a scar post-surgery. They have problem with sexuality. They are unsure about their desire for pregnancy and fertility, more often because of risk involved in pregnancy and the possibility of inheritance to their offsprings. They are also not aware of the contraceptive options available to them, and most importantly is their mental health as well. So this is the paper published looking at these adults with congenital heart disease. What do they know about reproductive health and risk? And from this paper, they found that less than 5% of adolescents would recall receiving information about contraceptives, and less than 15% would have received any information about pregnancies. About a quarter of them wanted information about contraceptive, and close to half of them would wish to receive information about pregnancies. So, how often do adolescent women discuss about their reproductive concern with their healthcare workers? This is another paper published just recently in 2022, looking into this issue, and they realized that self-reported reproductive health discussions were conducted very infrequently. Only 37% would discuss about transmissibility of a heart condition to offspring. About half would discuss about risk of pregnancy to their health, and about 1/5 would discuss about risk of hormonal contraception given their heart condition. And they reported most discussion were conducted with cardiologists rather than the gynecologist or the maternal fetal medicine. So let's look at menstrual disorder first. There are multiple papers which were published in the past looking into menstrual dysfunction, and all of these papers collectively found that the mean age of menarche is significantly different between those with adult congenital heart disease compared to those without, and about 68% of them would suffer from any form of menstrual cycle disorder compared to only 10 to 20% of those without adult congenital heart disease. Most frequent menstrual dysfunction was frequent menstrual bleeding. About 80% reported at least one menstrual complaint. Mainly 71% complained about cramping. About half would have irregular menses, half would have heavy periods, and more than 80% actually reported of taking any OTC pain relief. And we also have to put special consideration into those taking anticoagulations, because we know patients taking anticoagulation are at increased risk of menorrhagia. So the treatment for menstrual dysfunction include the levonorgestrel intrauterine system or any form of progesterone therapy with analgesia. Next, let's talk about sexuality. On all sexual function scores, women with congenital heart disease score less than general population, and the younger women seem to be more affected. And what are their sexual problems? This would include reduced libido, reduced lubrication, arousal, and sexual dissatisfaction. Many of them also suffer from dyspareunia. They have insecurity and fear and low self-esteem secondary to their physical appearance related to scar. Many of them also have difficulty with intrapersonal relationship. And now come to risk in pregnancy. So we cannot emphasize enough the importance of preconception care. It's important to carry out a thorough assessment to your patient before they embark on pregnancy. Medication checks is important to identify which are the pregnancy-friendly and which medication should be reconsidered. But do not stop any medication without discussion with the patient, with their cardiologist, and the maternal medicine consultants. We will also have to sensitively discuss about life expectancy, especially those with severe pulmonary hypertension, those with a Fontan palliation, because we know the possibility of shorter life expectancy, and hence they may or may not be able to live long enough to see their children grow into adulthood. MDT plays a crucial role in order to obtain a good pregnancy outcome. And we like to adopt the traffic light concept. Those who fall into the green zone would be okay to embark on pregnancy, of course, after optimizing other comorbidities as well. Those who fall in the amber zone would need optimization of their cardiac condition, and this has to be discussed with their cardiologist. And it's important not to discourage the patient from embarking on pregnancy, but instead telling them that it's better to optimize their condition, which would provide them a better pregnancy outcome. And obviously, those who fall in a red zone would need careful counseling and consideration, and we may discuss with them regarding other options, include adoption. But bear in mind, it's always very difficult to disallow or disagree mother from trying to embark on pregnancy. And it's only fair for a woman wanting pregnancy with her partner. Therefore, we should very sensitively address this issue. We will also have to discuss about the possibility of inheritance to their offspring. And last but not least, their general well-being and screen for other comorbidities as well, such as diabetes, obesity, sleep-breathing disorder, and so on and so forth. Also important to ensure their vaccination is up to date, because many of them are possibly more immunocompromised than those without heart problem. Hence, routine and annual influenza vaccine, COVID vaccine should be up to date. And also not to forget to check on their varicella zoster vaccination, rubella vaccination, and hepatitis vaccination as well. So the American Heart Association actually had come up with a set of tests and assessment, a recommendation for test and assessment before pregnancy. And this is a paper published in the journal Women's Health in last year in February, looking into how many of these women with adult congenital heart disease actually received recommended test and assessment before pregnancy. And they found that only 50%, which is half of them, received a complete blood count. Only 3% received cardiopulmonary tests. More than 20% actually had not received any form of recommended test or assessment, and less than 1% received all recommended tests. About 10% of women continue to have filled prescription for cardiac-related medication that may increase the risk of birth at the year before conception. And this is worrying because perhaps medication checks were not regularly conducted in the clinic. Hence, this may be missed and patient may actually embark on pregnancy while they are still on certain medication, which could be embryo or teratotoxic. So what's important in preconception care as well is to re-stratify this patient according to the severity of congenital heart disease. And this can be done using the modified WHO classification, although this is very widely used and universally used. However, the modified WHO classification actually only look at the disease per se, the diagnosis per se, and it does not take into consideration of the patient functional status, the patient past history of any adverse event. So there are other screening tool or scoring tool which may be slightly more accurate and can be also applied to re-stratify our patients. And this would include the Sahara and the CAPREC2, where they actually looked into the functionality, the functional status, and also past history of adverse event. And this would more accurately predict the risk of possible adverse outcome in pregnancy. So what are the conditions which are not recommended for pregnancy? Patients with Eisenmenger syndrome, patients with severe pulmonary arterial hypertension, those who are cyanotic, patients with spontan circulation with complication, patients with high-risk aortopathies, which are those about 4 to 4.5 cm of aortic root for Marfan syndrome, patients with severe systemic ventricular dysfunction, and those with severe mitral or symptomatic aortic stenosis. So we would say, hold on, let's not embark on pregnancy first. Let's discuss further with a multidisciplinary team. In these cases, perhaps sometimes we can also suggest for some surgeries, such as for patients with Marfan syndrome with an aortic root of 4 to 4.5 cm or bicuspid aortic valve with an aortic root of 4.5 to 5 cm, they can have a repair of the aortic root first. And those with valvular heart lesion perhaps can have a valve replacement first. Septal myectomy or heart transplant can be suggested to those with hypertrophic cardiomyopathy, especially those with the outlet obstruction. Pacemaker and ICD should be in place or should be recommended to patients with life-threatening arrhythmia as well. So do not discourage the patient from getting pregnant. So try not to say no to their wish to get pregnant, but just tell them, hold on first. Let's see what we can do to improve your condition in order to obtain a better pregnancy outcome. Because many a times when you try to stop someone from getting pregnant, you're actually chasing them away from getting proper care. So when it comes to antenatal care, it's important to know what's the implication of this adult congenital heart disease on pregnancy and vice versa. We know during pregnancy, there is significant hemodynamic cardiac changes in terms of heart rate, plasma volume, cardiac output, and obviously the mean arterial pressure, systemic resistance as well. And all these changes make a significant impact on the underlying condition which they already have. So this is a very nice illustration which showed a diagram of patients with different risk factors and how they should be managed during preconception care, antenatal, and during intrapartum. So what are the risks of adverse outcome From the maternal side, there is high possibility of cardiac events such as myocardial infarction, heart failure, stroke, thromboembolic event, hence never forget anticoagulants, arrhythmia, valvular dysfunction or thrombosis, endocarditis, high risk of severe morbidity and mortality, especially to patients with severe congenital heart disease, and also possibility of developing preeclampsia in pregnancy. On the fetal end, there is higher risk of miscarriage, preterm birth, fetal growth restriction because of a lower cardiac output, possibility of inheritance or recurrence in their offspring, teratogenicity because of medication, bleeding tendency more for patients on anticoagulants such as warfarin, and that does not just increase the risk of pregnancy loss, but the increased risk of intracranial bleed to the fetus, and neonatal and perinatal morbidity and mortality. So looking at the cardiac medications, we need to advise on the safety profile of this medication in pregnancy. When we want to recommend certain medication or advise on certain medication, it's extremely important to understand the embryology, know at which gestational age that this organ would develop, and hence whether this medication that they are on would have an impact on the pregnancy. So it's not always, the patient have accidentally take this medication, which is teratogenic in pregnancy, hence the pregnancy is certainly affected. So that is not true. So it depends at which gestational age these patients are taking medication and whether the baby has already been exposed to the medication, and then to define whether there is a high possibility of teratogenicity to the fetus or not. So what medications are not recommended in pregnancy? ACE inhibitor and ARBs. However, we would strongly recommend not to stop this medication prior to pregnancy itself. So you can tell the patient, be very sensitive to your period. So the moment you miss your period, you should attend to visit the maternal medicine doctor or your cardiologist, let them know that you are now pregnant, and then they can safely stop the medication by then. But obviously, if ACE inhibitor, it's one of the crucial medication for patient to stabilize the patient's condition, then additional counseling should be carried out, and you may need to consider continuing the medication as well. Angiotensin receptor neprilysin inhibitor is also contraindicated. Endothelial antagonist and rosiguat, these are the medications used for pulmonary arterial hypertension. Special consideration should be given to aldosterone antagonist because we know that these are anti-androgenic medication. However, if the baby is actually a female baby, then we may consider continuing the medication if the benefit outweighs the risk. Statins are now being studied to relook again at safety profile because it doesn't seem to be as teratogenic as before. Amiodarone, obviously we know that it can cause thyroid problem to the baby, but again, when it comes to emergency situation, in terms of stabilizing maternal condition, it can be used as well. And obviously warfarin as well, especially those with double valve and so on. We know that warfarin is actually dose dependent, hence high dose of warfarin may still have risk of embryopathy and intracranial bleeding to patient. So now we would have to carefully consider whether to really prescribe warfarin to patient in pregnancy, and this can be detailedly discussed when the patient comes to the cardiac obstetric combined clinic. Other medications that we need to take into consideration would be our uterotonic, such as ergometrin, carbopros, because these are potent vasoconstrictors and they may have significant impact on pulmonary and systemic vascular resistance, such as patients with pulmonary arterial hypertension, on those with general hypertension. And this should be avoided for these patients. Not to forget our low molecular weight heparin, which is important for patients as a prophylaxis for VTE. Now let's move on to intrapartum. We know that there's significant hemodynamic changes during labor per se, because labor actually induces augmentation of cardiac output. There's about 400 to 600 mils of blood returning to the blood circulation during each uterine contraction, and there's increased sympathetic activity during this contraction and during labor per se. So all this would increase patient's cardiac output, and hence and hence we have to be really cautious intrapartum monitoring these patients. Valsalva maneuver during the second stage can reduce venous return, reduce cardiac output, as well as increase oxygen consumption. Hence, we may need to consider shortening of second stage for patients with severe and significant cardiac condition, and this can be done by performing instrumental delivery. But instrumental delivery or shortening of second stage is not applicable, and I would say does not have to be mandatory to all patients with cardiac condition, because instrumental delivery does not come without risk. Choice of uterotonic have to be careful as well. As we mentioned earlier, carbopros may not be suitable for patients with a raised vascular or raised pulmonary or systemic vascular resistance. Discuss about role of epidural. Obviously, it reduces pain, it reduces sympathetic activity, but at the same time, it may sometimes plunge the blood pressure quite a bit, and hence it may have adverse impact on patients who actually depends on stable cardiac output. Immediate postpartum period is an abrupt rise of cardiac output. Therefore, within that first 24 to 48 hours is a crucial time that we have to monitor the patient closely. During postpartum period, there is again change in cardiovascular hemodynamic. We need to monitor the risk of acute pulmonary edema and heart failure in this patient. There is much higher risk of VTE in postpartum compared to antenatal period. Therefore, never forget to prescribe pharmacological VTE prophylaxis to our patient. Recheck the medication, because some of the medication may now be restarted, such as ACE inhibitor, such as warfarin after 72 hours if your patient after delivery, especially for patient who actually has undergone C-section. Long-term implication of pregnancy on their cardiac condition and vice versa, and never lose to follow up. Next, let's talk about inheritance to offspring. So when we talk about inheritance, obviously it involves genetic, and therefore involvement of the geneticist is important in counseling. Risk of recurrence depend mainly on the patient, whether there is any family history. So a 3-generation family history, including any consanguinity, should be completed by the clinician. Identify the inheritance pattern is important. Because we know that autosomal dominant condition happens in there is a 50% risk of inheritance to the offspring. Whereas congenital heart disease that arises de novo, the risk of recurrence to their offspring is only between about 3 to 5%. What about desire for pregnancy and fertility? Look at fertility. The American Heart Association actually conducted a study in Denmark, and this include both men and women, and they found that patients with simple or moderate congenital heart disease, most of them are not affected. Their fertility is not affected. Subfertility is most common seen in patients with cyanotic complexes, such as those with a Fontan palliation. Both men and women with congenital heart disease have lower birth rate compared to those without, independent of the severity of their congenital heart disease. And this perhaps is related to genetic factor, extra cardiac anomalies, the drugs like anticoagulants, and psychological factors. There is also other paper looking at the time to pregnancy, and they found that there is not much of difference in terms of time to pregnancy between those with or without the congenital heart disease. What about ovarian function? There is reduced ovarian function in patients with complex congenital heart disease. They're significantly lower than those without congenital heart disease. And AMH is also significantly lower in patients with severe congenital heart disease, such as those with Fontan circulation. regardless whether there is a reduce in oxygen saturation or not, their AMH remain reduced for those with congenital heart disease. So what about management? Investigation should be carried out as per general population, but beware of vasovagal reaction during cervical dilatation. Procedures such as hysteroscopy can cause fluid overload. Laparoscopy, due to creation of pneumoperitoneum, may have impact on the venous return and cardiac afterload. Hormonal stimulation may increase risk of thrombosis. However, just need to remember to prescribe anticoagulant as VTE prophylaxis because we know that in pregnancy itself, patients is exposed to very high hormonal stimulation. Hence, that should not, prevent them from getting any fertility treatment. OHSS, a patient can be easily compromised when it comes to OHSS, and we certainly would recommend for single embryo transfer to reduce the risk that may be aggravated by multi-fetal pregnancy. Next, let's talk about contraception. So less than 4 in 10 women with congenital heart disease had any form of contraception, and only about 10% of patients with this problem actually use the most effective contraceptive method. About a quarter use moderately effective method, and among women with congenital heart disease who had gynecological encounter in previous years, about 60% used any permanent or reversal prescriptive contraceptive method, and among those who had a cardiologic encounter, less than 40% actually used any permanent or reversible prescription. So those who actually went to gynecology clinic, there were more of them who actually use some form of contraceptive method compared to those who went to cardiology clinic. Therefore, it's important to remind our cardiology counterpart, our cardiology colleagues, that it's still important to discuss about contraception, and if they need help, they can always refer the patients to us. And finally, mental health. So this is a paper published looking at the reproductive health in adults with congenital heart disease, looking at fertility, sexual health, and assisted reproductive technology and contraception. And they found that around 11% of women actually reported feeling unattractive due to their surgical scar, especially during the time of sexual intercourse. Many of them also have limitation to physical and social activity. That can be a consequence of abnormal uterine bleeding. Close to about 30% actually had depression. About 24% are concerned about their sex life. About a quarter of them fear of being infertile, and more than 60% actually fear of passing their condition to their offspring. So recognize anxiety, fear, and depression. Refer these patients to psychiatrists as early as possible. So in summary, women with congenital heart disease face unique challenges throughout their life. And menstrual disorders are more prevalent in patients with adult congenital heart disease than those without. Discuss about sexual health, pre-pregnancy care, pregnancy, and contraception every time when you see the patient. Referral to MFM team should be considered for those planning for pregnancy for a thorough assessment. Multidisciplinary team is the key and the core to successful pregnancy. Fertility is typically unaffected in those with simple or moderate congenital heart disease, but their AMH may be decreased, especially in those with severe cases. Progesterone-based contraceptive methods are safe for all these women. However, pay attention and be cautioned when you're using or inserting an intrauterine device, because that can cause vasovagal reaction. And mental health disorder may affect women with adult congenital heart disease, so engage in discussion with them and offer support to them. With that, I thank everyone for their attention.